DALK has become the gold standard technique for patients with stromal diseases. While performing DALK, the most wanted result is to obtain a type 1 big bubble, which indicates the appropriate air dissection between posterior stroma and Dua's layer. The presence of Dua's layer is key to understand the formation of type 1 and 2 big bubbles. Dr. Dua described the layer in 2013 and stated that this 15 to 20 microns layer contains mainly collagen type 1, 4 and 6, which are more present in this layer than the rest of the corneal stroma. Also, this layer lacks keratocytes. The absence of CD34, which is a keratocyte cellular marker, confirms it. Normally, injected air will diffuse through the corneal stroma and, on reaching the posterior lamella, it separates the Dua's layer from the deep stroma, forming a type 1 big bubble. A defect in the Dua's layer may allow air passage to separate the Descemet's membrane, resulting in the formation of a type 2 big bubble. Before Dua's discovery, DALKs had unexpected outcomes and more complications. The Descemet membrane perforation rate was around 10.5%. This case shows a macroperforation occurring after the opening of the bubble's roof, which ends in a PK conversion. And here there is a macroperforation occurring while removing peripheric stroma. This video shows a microperforation during stroma resection. We can see that the perforation didn't happen due to a bad cut, but to the fact that holding the tissue generates a certain force that the eye can't take. In this other case, we can clearly see the formation of a peripheric bubble, which indicates it's a big bubble type 2. After keratectomies were performed, now it's time to puncture the big bubble. This may be considered one of the most risky steps in the surgery, because of the probabilities of an accidental central perforation. Luckily, that didn't happen here. It was decided to dissect the rest of the stroma. Because of the greater fragility of the tissue due to the big bubble type 2, it's preferred to dissect just 4 to 5 central millimeters. Dissecting more tissue to the periphery may result in higher chances of a perforation. The discovery of Dua's layer allowed a better understanding of the dynamics of the air within the cornea. This knowledge would allow taking the appropriate measures to reduce the frequency of complications. The article Factors Affecting Formation of Type 1 and Type 2 Big Bubble During Deep Anterior Lamellar Keratoplasty, published on the current ASCRS magazine, studied 322 eyes where DALK was performed. 102 eyes had corneal scarring secondary to herpes simplex keratitis, 117 had keratoconus, and 39 had other corneal scarrings. Big bubble type 1 was achieved in 45.7% of cases, type 2 in 33.9% and type 3 in 3.4%. Every patient ended up with lamellar dissection without converting to PKP. Keratoconus patients had significantly higher number of type 1 big bubble compared to patients with corneal scars and corneal dystrophies, whereas patients with corneal scarring had higher number of type 2 big bubble compared to keratoconus and corneal dystrophy groups. In keratoconus patients, 83.8% of patients had type 1 big bubble and 2.6% had type 2 big bubble. The relatively high incidence of type 2 big bubble in this study may be attributed to the large number of eyes with corneal scars. The study says the corneal edema during active herpes may weaken the adhesions between the corneal stroma, including Dua's layer, and the Descemet's membrane. After stromal edema decreases, scarring may cause a firmer adhesion between stroma, Dua's layer and Descemet's membrane, leading to difficult separation from the overlaying stroma via air injection when attempting to form a type 1 big bubble. Descemet's membrane perforation is one of the main complications of DALK. Previous studies have reported Descemet's membrane perforation during DALK ranging from 5% to 19%, needing a conversion to PKP in up to 12% of cases. But that is only true in type 1 big bubbles. Mohamed Gouweida's study, Intraoperative Review of Different Bubble Types Formed During DALK, describes a conversion rate up to 86% in patients with big bubble type 2 when trying to reach the descemetic plane. So, what do we do when we get a type 2 big bubble? The first step is to confirm the presence of the big bubble type 2. The bubble forms from the periphery. The bubble is off-centered and it exceeds the trepanning area. The transillumination technique shows the waning moon sign, revealing the inner reflection of the light when checking with the light probe. When to unroof a type 2 big bubble? It's not advisable to unroof the type 2 big bubble. It's safer to continue with the manual technique till reaching a predescemetic plane. Should I puncture the big bubble type 2 when I manually achieve the predescemetic plane? It depends on the surgeon's experience and the considered risk of pupillary blockage. The trapped air will get reabsorbed in 2 to 3 days if it's not punctured. In conclusion, manual technique is the way to go when you get a type 2 big bubble. The benefits of preserving the endothelium outweighs the limitations in vision secondary to residual stroma in the manual technique.